Hey everyone, and welcome back. Today we're going to be doing a deep dive into some excerpts that you sent us from the World Health Organization's AWARE book.
Oh, interesting.
Yeah, specifically we're going to be looking at the chapter on hospital-acquired pneumonia.
Okay, great.
So, HAP, as you all probably know.
Oh, for sure. As medical microbiologists, this is something that we see quite often.
Yeah, you're no strangers to this. But hopefully we can get some fresh perspectives.
Yes, definitely. Especially with antibiotic resistance always evolving, it's great to revisit the essentials.
Absolutely.
Yeah.
So we're going to kind of hit all those key points. We'll talk about the definition, the clinical presentation, how we nail down the diagnosis with those lab tests.
Right.
Then, of course, treatment strategies, especially the specific antibiotics recommended by AWARE. We'll even look at those dosages that you love so much.
Yes, of course. Always interested in those finer details.
And, of course, we'll explore the pathophysiology, epidemiology, and the most likely pathogens that we really need to be thinking about with HAP.
Okay, sounds good.
To make things a little more fun, we'll also sprinkle in some exam-style questions.
Oh, fun. Love a good challenge.
Right. Ready to test your expertise a little bit.
Absolutely. Let's start with the basics. What exactly is hospital-acquired pneumonia? How do we define that?
Right. So the AWARE book, it defines hospital-acquired pneumonia as an acute lung infection that develops 48 hours or more after a patient has been admitted to the hospital.
Okay, so it's all about picking something up in the hospital environment.
Exactly.
Makes sense. But as we know, it can be tricky to distinguish from community-acquired pneumonia sometimes, right?
Yeah, absolutely. You know, that 48-hour mark, it's more of a guideline for tracking and surveillance.
Right.
We can't always completely rule out those community bugs just because someone's been in the hospital for a few days.
And then there's the whole challenge of diagnosing HAP in patients who aren't on ventilators.
Yeah, for sure.
That can be a real gray area. It can sometimes lead to overdiagnosis and unnecessary antibiotics.
Oh, yeah. Definitely not what we want. So let's say we suspect HAT, right? What are we going to be looking for in terms of clinical presentation? What are those telltale signs?
Well, the symptoms are often pretty similar to other types of pneumonia. You know, cough, shortness of breath, fever, the usual suspects.
Right.
But those are pretty nonspecific, so it's vital to consider other diagnoses like maybe a pulmonary embolism before we jump to conclusions.
Yeah, that makes sense. So history and physical exam are essential, but then to really confirm things, we need to look at those lab tests. What does AWARE recommend?
So those core tests would be blood cultures. Microscopic examination and culture of respiratory samples is really crucial as well.
Okay.
And depending on the situation, we might consider urinary antigen testing for Legionella and Streptococcus pneumonia.
Yeah. And of course, in this day and age, we can't forget about those viral culprits.
Absolutely. A nasopharyngeal swab for influenza and SARS-CoV-2 is a must.
Right, because those can be pretty severe, especially in hospitalized patients. But I guess a positive culture doesn't always equal an active infection, does it?
No, that's right. We always have to distinguish between colonization and true infection.
And that can be a challenge, especially with HAP.
It can be, especially in patients who have been hospitalized for a while. Their respiratory tracts might be colonized with all sorts of bacteria. Some are harmless, and some are potential troublemakers.
Right. So we need to consider the whole clinical picture, not just a single lab result. So what about some of those other lab tests that we can use? Like what can help us figure out the severity of the infection and whether we're dealing with bacteria or a virus?
Yeah, that's a good point. So AWARE mentions some helpful indicators. Blood pH and gases can give us some clues.
Okay.
White blood cell count is another one.
Yeah.
And C-reactive protein.
Oh, yeah.
But remember, interpreting these always needs to be done in the context of the pre-test probability.
Oh, yeah. Pre-test probability. I think some of our listeners might need a quick refresher on that.
Sure. Essentially, it's how likely the patient is to have bacterial versus viral pneumonia based on their clinical presentation. It helps us avoid overreacting to, say, a slightly elevated white count if the patient otherwise looks like they have a viral infection.
Right. So we don't jump the gun.
Exactly.
Okay. What about procalcitonin? I know that's sometimes used to try and distinguish between bacterial and viral pneumonia. What are your thoughts on that one?
It can be helpful, yes, but AWARE does mention that it's not always readily available, especially in smaller hospitals.
Right. So not everyone has access to that.
Yeah.
All right. So let's say we've got our lab tests in order. What about imaging? AWARE seems to put quite a bit of emphasis on those chest x-rays.
Chest x-rays are definitely a cornerstone. They help us rule out other conditions that could be mimicking pneumonia.
Okay.
And they can potentially help us avoid unnecessary antibiotic use.
Sounds good. But I imagine there's some caveats.
Oh, definitely. Chest x-rays, especially in HAP, can be tricky. Findings can be nonspecific. And interpretation can be tough, especially in patients with pre-existing lung conditions.
So, another reminder not to rely on a single test in isolation. It's all about piecing together those different pieces of information.
Exactly. It's like a puzzle. We need those clinical clues, the lab results, and the imaging all coming together to give us that clear picture.
Absolutely. Now let's move on to the part everyone loves talking about, treatment. This is where things get really interesting.
Absolutely. AWARE does a good job of providing us with a framework for choosing antibiotics. But before we jump into specifics, what are those overarching principles that we need to keep in mind when treating HAP?
Right. The first and foremost is the severity of the illness. Is this a mild case, or is the patient critically ill and needing intensive care?
Yeah, that's a big one.
Because obviously that dictates the urgency and how aggressive we need to be with treatment.
Right. And we also need to factor in those risk factors for multi-drug resistant organisms. We've talked about those a bit already.
Oh, yeah, absolutely. So we're thinking previous antibiotic use, how long they've been in the hospital, those local resistance patterns in our area, all those clues that tell us how strong we need to go with those antibiotics right out of the gate.
Exactly. AWARE recommends tailoring the initial antibiotic choice based on a balance of risk and coverage.
Oh, okay.
Hitting hard if needed, but always striving for that targeted approach to minimize resistance.
I like that risk and coverage, finding that sweet spot. Okay, so let's get into the nitty-gritty. What specific antibiotics does AWARE recommend for HAPP? I know you're eager to talk about those dosages.
I am, always. So for non-ventilated patients with HAP where the risk of multi-drug-resistant infections is low, AWARE suggests amoxicillin clavulanate as a first-line option.
Okay, good old amoxicillin clavulanate.
Wow.
What's the typical dosage for that?
For adults, the AWARE guidelines recommend either 1 gram of amoxicillin and 200 milligrams of clavulanate intravenously every 8 hours, or 875 milligrams of amoxicillin and 125 milligrams of clavulanate orally every 8 hours. For children, the dosage is adjusted based on weight, and AWARE has those specific weight-based recommendations in the book.
Okay, perfect. So if it's a low-risk patient, amoxicillin clavulanate is a good place to start. But what if we see those red flags? What if we suspect those multi-drug resistant organisms are at play? What do we do then?
Then we need to step up our game. AWARE recommends considering options like ceftriaxone, cefotaxime, or piperacillin-tazobactam in those higher risk scenarios.
Let's break those down a little bit. Ceftriaxone, what's the usual dose for that one?
For adults, AWARE recommends 2 grams intravenously or intramuscularly every 24 hours, or 1 gram intramuscularly every 24 hours. And again, they have specific pediatric dosages in the guidelines.
Okay. What about cefotaxime? How does that one stack up?
AWARE recommends 2 grams intravenously or intramuscularly every 8 hours for adults. And as with the others, specific pediatric dosing is available.
Okay, so we've got ceftriaxone, cefotaxime, and then the last one you mentioned was piperacillin-tazobactam.
Yeah, that's right.
What are the key considerations of that one?
So piperacillin-tazobactam is our powerhouse. It offers anti-pseudomonal coverage, which is crucial for patients at risk of Pseudomonas aeruginosa infection.
Right.
The typical adult dose is 4 grams of piperacillin and 500 milligrams of tazobactam intravenously every 6 hours. And as always, AWARE outlines those pediatric doses.
Perfect. So we've got our big guns ready if we need them. But regardless of which antibiotic we choose, we always need to be thinking about de-escalation.
Right. Absolutely. Once we have those culture results, or if we see clear clinical improvement, the goal is to narrow the spectrum of antibiotics.
Right. Target the culprit and minimize the risk of resistance.
Exactly.
And whenever possible, switching to oral antibiotics is preferred.
Yeah, it gets those patients out of the hospital sooner.
And reduces those IV-related complications.
Right.
Okay, so speaking of duration, what does AWARE recommend? How long do we need to keep those patients on antibiotics for HAP?
They recommend a treatment duration of 7 days for HAP, but they emphasize that the diagnosis should be reassessed at that point. If the patient isn't clinically stable, we might need to extend the treatment.
Right, so 7 days is like that initial target, but flexibility is key.
For sure.
Okay, now let's shift gears a little bit and talk about those bugs that are causing those infections. Let's dive into the pathophysiology, how these little guys actually invade and wreak havoc in the lungs.
It's a bit of a multi-step process, but it often begins with colonization of the oropharynx, so basically the back of the throat.
Okay, so they're just hanging out back there waiting for their chance.
Exactly. And unfortunately, the hospital environment, even with all our infection control measures, can provide those opportunities.
Right. Makes sense.
Medical equipment, healthcare providers' hands, those can be sources of these pathogens, even just the air itself.
Oh, wow. Okay, so they're lurking everywhere. So how do they go from just hanging out in the throat to causing that full-blown lung infection?
Aspiration is often the main culprit. Those secretions from the oropharynx, now carrying those potential pathogens, get inhaled into the lower respiratory tract into the lungs.
Oh, so they take a little detour.
Right. And once they reach the alveoli, those tiny air sacs responsible for gas exchange, the real trouble begins.
Right. That's where the battle takes place.
Yeah. It triggers that inflammatory response, leading to all those classic pneumonia symptoms we talked about. Cough, fever, difficulty breathing.
Okay, but why are hospitalized patients more likely to aspirate? I mean, why are they more prone to this than the average person walking down the street?
Good question. Well, some patients have underlying conditions that affect their ability to swallow or clear those airways effectively. Others might be sedated, which makes them more susceptible to aspirating those oropharyngeal secretions.
Oh, okay.
And of course, intubation is a major risk factor.
Right, because it bypasses all those natural defenses against aspiration.
Exactly. Plus, those endotracheal tubes themselves can become colonized, creating a direct pathway for bacteria to enter the lungs. It's a bit of a perfect storm.
Right.
But it's not just aspiration. Those pathogens can also reach the lungs through the bloodstream, particularly in patients with sepsis, or by directly spreading from a nearby infection.
Oh, wow. So it's a multi-pronged attack. Okay, let's zoom out a little bit and talk about the epidemiology of HAP. How common is it? Who's most at risk?
HAP is a major global health issue. It's one of the most frequent healthcare-associated infections, and it contributes significantly to illness and death in hospitalized patients. The exact numbers can vary depending on the patient population and how we define HAP.
Right.
But we generally see higher rates in mechanically ventilated patients and those in intensive care units.
Okay, which makes sense. We've already talked about intubation as a major risk factor. What are some other things that make patients more susceptible to developing HAP?
On the patient side, there are things like difficulty swallowing, weakened immune systems, and chronic lung diseases. On the treatment side, prolonged hospital stays, especially in the ICU, using a nasogastric tube for feeding, and previous exposure to antibiotics can all increase the risk.
So a whole web of factors, and we know HAP is a serious condition. It's often more deadly than community-acquired pneumonia.
Yeah.
And that ventilator-associated pneumonia, the VAP, is the most dangerous form. But what are the most likely culprits behind HAP? What are those pathogens lurking in the shadows waiting to strike?
Let's talk about that. As we've already hinted at, a whole host of bacteria and viruses can be responsible for HAP.
Right.
Figuring out which one is most likely in a given case requires a bit of detective work.
Okay, I love a good microbial mystery. So what are our key clues?
One important distinction is between early onset and late onset HAP. Early onset typically pops up within the first 4 days of hospitalization and often involves those familiar community-acquired pneumonia pathogens.
So we're thinking Streptococcus pneumonia, Haemophilus influenza, maybe some of the usual respiratory viruses.
Exactly. But as the hospital stay drags on, the risk of multi-drug resistant organisms starts to climb.
Right, so that's where those gram-negative baddies like Pseudomonas aeruginosa and Acinetobacter baumannii enter the picture.
Precisely. These are the ones that can really cause problems, often resistant to multiple antibiotics. Late onset HAP is a different ballgame.
Yeah, for sure. And previous antibiotic exposure really complicates things, doesn't it?
It absolutely does. Prior antibiotic use is like a training ground for resistance. If a patient has recently received antibiotics, they're far more likely to be carrying those multi-drug resistant organisms.
So it's survival of the fittest, bacterial style. It's fascinating and terrifying all at the same time.
I agree. It highlights why we need to be careful with antibiotic use.
Absolutely. Okay, let's talk more about these microbial villains. We've mentioned Pseudomonas aeruginosa and Acinetobacter baumannii. What makes them such formidable opponents?
Well, they're both incredibly adaptable.
Yeah.
They can survive on surfaces and equipment, which makes them masters of the hospital environment. They're also inherently resistant to many antibiotics, and they can acquire resistance genes from other bacteria.
Sounds like something out of a comic book. The supervillains of the bacterial world.
In a way, yeah. They can be a serious threat, especially to those with compromised immune systems.
Right. And we can't forget about MRSA. What role does it play in HAP?
Oh, MRSA is a major player. Methicillin-resistant Staphylococcus aureus. Its resistance to many common antibiotics makes it a real concern.
Definitely. So thinking about MRSA coverage is essential when choosing that initial antibiotic regimen,
Absolutely.
especially if the patient has those risk factors we talked about.
And remember, the prevalence of MRSA can vary greatly between hospitals. Knowing your local patterns is crucial.
Oh, for sure. Okay, so we've got our usual suspects. How do we actually go about identifying the culprit in a patient with suspected HAP?
It all starts with getting the right samples. We need blood cultures, sputum, and potentially bronchoalveolar lavage fluid if the situation calls for it.
Okay.
And timing is key. We want those samples before we start antibiotics.
Right, so we don't muddy the water.
Exactly.
So we whisk those samples off to the lab, and then what? What happens next?
Well, the gold standard is still culture, growing those organisms to identify them.
Right.
And then we perform antimicrobial susceptibility testing to see which antibiotics are effective.
Makes sense. So that's how we tailor treatment to that specific pathogen.
Right.
But what about those faster techniques? Are there any quicker ways to identify these pathogens?
PCR, polymerase chain reaction, can sometimes provide rapid identification.
Oh yeah, PCR. It's amazing. It can detect even tiny amounts of DNA or RNA from the pathogen.
Exactly. It can be a real game changer.
Especially when time is of the essence.
Absolutely.
Now, we've talked a lot about the challenges of diagnosing HAP, especially in those non-ventilated patients. How do we know if we're dealing with a true infection versus just colonization, especially with those respiratory samples?
That's where clinical judgment comes in. A positive culture doesn't automatically equal infection. We have to consider the whole picture, their symptoms, vital signs, other lab results, and be cautious about overinterpreting positive cultures from non-invasive samples.
It's putting together a puzzle. You have to look at all the pieces.
Exactly. And overtreating with antibiotics can do more harm than good.
Right. Fueling resistance, potentially leading to other complications. So this really brings us back to the importance of those AWARE guidelines.
For sure.
They provide that framework for approaching HAP. But ultimately, it's up to us to apply those principles thoughtfully and individualize care for each patient.
Absolutely. Context is everything.
Okay, so now that we've reviewed all that, are you ready for a little knowledge check? Let's see how much you've absorbed.
Hit me with it. Let's do it.
Okay, so first question. True or false that 48-hour post-admission cutoff for defining HAP is a rigid rule with no exceptions? What do you think?
That's a tricky one, but I'd have to say false. It's more of a guideline than a hard and fast rule.
You got it. It's helpful for surveillance and categorization, but those individual patient circumstances are really important. Okay, question number 2. What is the most important factor when deciding whether to start those empiric antibiotics for suspected HAP?
I'd say it's a balancing act. You need to consider the severity of their symptoms, those risk factors for multi-drug resistant infections that we talked about, and then weigh that against the potential downsides of using broad-spectrum antibiotics.
Well said. It's definitely not a one-size-fits-all approach. All right, ready for question number 3. This is a multiple choice. Which lab test is most useful for differentiating between bacterial and viral pneumonia in patients with HAP? Is it A, white blood cell count, B, C, reactive protein, C, blood pH in gases, or D, procalcitonin?
Tough one. Let me think.
All right, time's up. The answer is D, procalcitonin. Although those other tests can give us some clues, procalcitonin is generally more specific for bacterial infections.
Ah, right. I should have remembered that.
But you did bring up a good point earlier. Access to procalcitonin testing isn't always available, especially in those smaller hospitals.
That's right. Yeah.
All right, we got 2 more. Question number 4. Why is it so important to consider the possibility of MRSA when choosing an empiric antibiotic regimen for HAP?
Well.
Think back to our discussion of those multi-drug resistant organisms.
Right. MRSA. Because it's so good at resisting so many of those commonly used antibiotics, if we don't cover for it from the beginning, it can really lead to treatment failure.
Exactly. We got to stay one step ahead of those bugs.
Yeah.
All right, last question. Question number 5. This is another tricky one. What is the primary reason for using selective oral decontamination or selective decontamination of the digestive tract in ICU patients?
Oh, okay. Let me see.
Remember our discussion of preventing ventilator-associated pneumonia?
Right. So those interventions are aimed at reducing the amount of bacteria in the mouth and the gut, respectively, to prevent them from moving into the lungs.
You got it. But as we discussed, it's kind of a double-edged sword because although they might help in preventing pneumonia in some cases, We're also a little bit worried about the potential for promoting antibiotic resistance.
Right, yeah. It's a delicate balance for sure.
It is. Well, I think that was a pretty good workout for our brains. Hopefully those questions helped us remember some of those key concepts that we've talked about.
Yeah, it's a good review.
Now, I want to move on to the next stage of our HAP investigation. Let's talk about imaging, specifically those chest x-rays, which can be so tricky.
Oh, yeah.
We've touched on some of the limitations, but I would love to get your take on navigating those interpretive challenges.
Yeah, I mean, like we said, chest x-ray findings in HEP can be really non-specific. All sorts of things can cause those opacities. It can be tough to tell HEP apart from other conditions.
Right. And especially when patients have pre-existing lung issues, it can be even more challenging to interpret.
Oh, for sure, for sure.
So how do we avoid those misdiagnoses and make sure we're not barking up the wrong tree?
I think it really comes down to taking that holistic approach. We have to consider the entire clinical picture. You know, the patient's history, their symptoms, what we're seeing on physical exam. And sometimes we just need to order some more tests. You know, a CT scan, maybe some blood tests to get those inflammatory markers or those cultures to really pinpoint exactly what's causing the infection.
Right. It's not always a quick and easy answer.
No, not at all.
It's about taking all that information and using it to make the best decision. Now, I want to talk about some of those controversies in how we treat HAP. One that always comes up is the use of vancomycin to cover for MRSA.
Oh yeah, the vancomycin debate. It's a hot topic among us infectious disease folks.
For sure. So what are those main points of contention when it comes to using vancomycin?
It boils down to whether we should be including vancomycin in that initial antibiotic regimen, even if we don't have clear risk factors for MRSA.
So some people are in that better safe than sorry camp, wanting to cover for MRSA just in case, while others are more worried about overuse and how that contributes to resistance.
Right, and there's no easy answer. It often comes down to the individual clinician's judgment, what the local patterns of MRSA are like, and how healthy the patient is overall.
Right. It's all about context. Okay, before we wrap up, I want to circle back to prevention. We've mentioned some general principles, but what are some more specific things that we can do in the hospital setting to really keep a HAP at bay?
Well, I think preventing HAP requires a multi-pronged approach. You need those individual patient-level interventions, but also those broader system-wide strategies to really create a culture of prevention.
Let's start with those patient-level interventions. What are some things that we can do to reduce the risk of HAP in our hospitalized patients?
Hand hygiene, it's so basic, but it's probably the most important thing we can do.
Yeah, absolutely.
Both healthcare providers and patients need to be really diligent about washing their hands, especially after contact with any bodily fluids or anything that could be contaminated.
For sure. And we talked about oral care, but I'm curious, why is that so important in preventing pneumonia?
Well, the mouth is a breeding ground for all kinds of bacteria.
Oh, yeah.
And they can easily get aspirated into the lungs, especially in patients who have breathing tubes or who have trouble swallowing. Keeping the mouth clean helps keep those bacteria in check.
So regular brushing, flossing, maybe even an antiseptic mouthwash can really make a difference.
Absolutely. And elevating the head of the bed, making sure patients aren't overly sedated, especially those who are at high risk of aspirating, are important too.
Right. It's about optimizing the patient's own ability to protect their airway.
Exactly.
Now, what about those system-wide approaches?
Yeah.
What can we do at the hospital level to really create that culture of HAP prevention?
Well, infection control protocols are essential. That means meticulous cleaning, disinfecting patient rooms, making sure equipment is properly sterilized,
Right.
making sure everyone is using personal protective equipment correctly, and making sure hand hygiene is a top priority for everyone.
So it's about creating that clean and safe environment for our patients.
What about antimicrobial stewardship? How does that play into HAP prevention?
Antimicrobial stewardship is crucial. It's about using antibiotics appropriately, choosing the right drug, the right dose, for the right duration. And we need to monitor our patients closely to see how they're responding to the treatment.
Because overusing antibiotics just gives those resistance mechanisms a chance to develop and spread.
Exactly. And like we've talked about, those antibiotic-resistant organisms are a huge challenge with HAP. Infections become harder to treat, and outcomes for patients can be worse.
So antimicrobial stewardship is about using these powerful tools wisely, not just throwing antibiotics at every problem.
Right, exactly.
We talked about selective decontamination as a possible strategy for preventing ventilator-associated pneumonia, but there were some concerns about it potentially contributing to resistance. Can you Elaborate on that a bit?
Sure. So with selective decontamination, we use those non-absorbable antibiotics to try and knock down the bacteria in the mouth and the gut.
The hope is that by reducing the number of bacteria there, we can stop them from going to the lungs and causing pneumonia. And there is some evidence that it can work, especially for ventilator-associated pneumonia. But the worry is that by using these antibiotics, we might accidentally be helping those resistant strains to grow.
So it's like we're weeding out the susceptible bacteria and leaving behind the ones that have figured out how to survive.
Exactly. And with antibiotic resistance becoming such a big problem, that's a real concern.
So it sounds like the decision to use selective decontamination is a tough one.
Yeah, you have to weigh the potential benefit for the individual patient against the risk of making that resistance problem worse.
Wow, we've covered so much ground today. We really have explored just about every aspect of hospital-acquired pneumonia.
It's been a very thorough discussion, for sure. We've talked about the definition, epidemiology, diagnosis, treatment, and prevention. It's a lot to take in.
And I think the main takeaway is that as medical microbiologists, we're dealing with much more than just those bugs in a petri dish. It's complex. We need to consider patient characteristics, the hospital environment, those ever-changing resistance patterns. It's a balancing act, trying to do the best for our individual patients while also thinking about the bigger picture of public health.
Absolutely. It's challenging, but it's also really rewarding work.
It is. And maybe the most important message to take home is that everyone has a role to play when it comes to tackling HAP and promoting antimicrobial stewardship. It's not just on us, the medical microbiologists. It's everyone from individual clinicians to hospital administrators. Everyone needs to be working together.
Couldn't agree more. We're all in this together.
So to wrap up this deep dive, I want to leave everyone with a question to think about as they continue this important work. We've talked a lot about how vital antimicrobial stewardship is, but it's a complex issue that goes far beyond just what happens in the hospital. So how can we as medical microbiologists be more effective advocates for antimicrobial stewardship? Not just within our own institutions, but on a broader societal level. How do we change those attitudes and behaviors to make sure these life-saving drugs continue to work for future generations?
That's a really important question, and it's a challenge that we all need to face head-on. Antimicrobial stewardship, it's not just about following guidelines. It's about really changing how we think about antibiotics and making sure everyone understands how crucial they are.
Right. We need to move away from that take an antibiotic for everything mindset.
Yeah.
They're powerful drugs, but they're not a cure-all, and overusing them can have some serious long-term consequences.
Absolutely. So what are some of the biggest obstacles we face when trying to promote antimicrobial stewardship, not just within our hospitals, but in society as a whole? I think one of the biggest challenges is education. We need to do a better job of explaining to people why it's so important to use antibiotics responsibly. We have to help them understand the risks of overuse, both for themselves and for public health.
Right, because it's not just about the individual patient, it's about protecting those antibiotics for everyone. So how do we get that message across effectively? How do we make sure people are really listening and taking it seriously?
It's about communication. We need to explain those risks in a way that makes sense to people without all the medical jargon. We need to make it personal.
Right, make it relatable.
And build trust. We need to let people know that we're not trying to withhold treatment. We're trying to make sure those antibiotics are there when they're really needed.
Absolutely. And it's not just about patient education. It's also about making sure we're all on the same page within the healthcare system.
Oh, yeah, for sure. Antimicrobial stewardship is a team effort.
Right. We have to work with doctors, nurses, pharmacists, everyone who is involved in prescribing or administering antibiotics. So that means good communication, sharing information, working together to make sure antibiotics are being used appropriately.
And that collaboration needs to extend beyond the hospital. We need to work with policymakers, public health experts, even the pharmaceutical industry to develop those broader strategies for antibiotic stewardship.
Yeah, it's a big picture issue. It's not something that we can solve in isolation. So what can we do? What concrete steps can we as medical microbiologists take to really champion antimicrobial stewardship? What can we do to make a difference?
Well, I think we need to lead by example. We need to be those role models within our own institutions.
Okay, so what does that look like in practice?
It means educating our colleagues about best practices for antibiotic use. It means putting those stewardship guidelines into place and making sure they're actually being followed. It means tracking antibiotic use, looking for patterns, looking for areas where we can improve.
So we need to walk the walk. We need to show that we're taking this seriously.
Absolutely. And we need to be active in research. We need to be looking for new ways to diagnose and treat infections that don't rely so heavily on antibiotics.
Right. And we need to support the development of new antibiotics that can target those resistant strains that keep popping up. It's like a never-ending race.
It is. We always have to be one step ahead.
And something that we haven't talked as much about, but that's incredibly important, is education. We need to educate the next generation of healthcare professionals about antimicrobial stewardship. We need to make sure they understand the importance of using these drugs responsibly.
Yeah, we have to pass the torch, so to speak.
And make sure they're equipped to face those challenges that are coming down the road.
Yeah.
It's an exciting time to be in this field, and there's so much important work to be done. But if we all work together, if we collaborate and share our knowledge, we can make a real difference.
I completely agree. It's a challenge worth taking on.
Well, I think that's a perfect note to end on. We've covered a lot of ground today. We've explored all the ins and outs of hospital-acquired pneumonia, from the bacteria that cause it to the antibiotics we use to treat it.
Yeah.
We've talked about those challenges in diagnosis and treatment, and we've really delved into the importance of prevention and antimicrobial stewardship.
It's been a great discussion. I always learn something new when we talk about this stuff.
You too, me too. To our amazing listeners, thank you so much for joining us on this deep dive into the world of HAP. We hope you found it informative, and we hope you'll keep those brains buzzing and stay curious about the world of microbiology.
And remember, every single one of you has a role to play in the fight against antibiotic resistance. So stay informed, stay engaged, and keep those conversations going.
Until next time, everyone, stay safe, stay healthy, and keep learning.